Hello everyone, welcome to today's INICET Prepathon. Sorry. Hi guys, welcome to today's live session on INICET Recall. So I welcome you all, and to start with the disclaimer, all the MCQs that will be discussed in today's session are as recalled by you guys and through various sources, and absolutely there is no conflict of interest whatsoever, and all the credits to respective owners for images and their sources. So this pie chart I had put up in our last class during the INICET Prepathon, and as you can recall, I had said that during last 5 years, critical care, triage and ATLS, history and pharmacology, these topics have become indispensable. They have become evergreen topics, and questions will come from these topics. And as discussed earlier, in this session, we saw 9 questions coming from anesthesia alone, and out of these, 3 questions have come from the chapter triage and ATLS. That's a very big number. That's about 1.5% of the entire paper. And if you went through the app, it is just a 30-minute discussion from which 3 questions have come. It was followed by 3 questions from pharmacology, 1 question each from airway management and critical care. That too from basic life support, which is very important for any exam. Along with this, we saw 1 question that was overlapping with general surgery. So to make it easier, my friend Dr. Nishant has already discussed 3 of the questions in his recent discussion. So these 3 questions are from the chapter triage and ATLS, and we won't be spending much time on these. So the first question was, patient requiring immediate care in casualty will be triaged as red tag, and in primary survey we will be doing airway, breathing, circulation, disability assessment and environment exposure. So all these will be covered under primary survey, and chest x-ray, intubation and ICD for any pneumothorax or tension pneumothorax are all part of primary survey, except the full body or the whole body CT scan, which is part of secondary survey. So these 2 are from the ATLS manual itself. And the third question, that is, they had shown an x-ray of a patient who was brought to emergency with a stab injury to the right side of the chest, and he is in stage of hemorrhagic or hypovolemic shock with a tachycardia, hypotension and tachypnea, and there is decreased breath sounds on the right side of the chest, and the x-ray was like this. So there was whiteout lung with a mediastinal shift, and they were asking, what does this x-ray show? So this x-ray shows hemothorax. So we are not going to spend much time on these questions because these have been elaborately discussed by Dr. Nishant in his recent session 2 days back. So right away, starting with pharmacology questions. So the first question here is, which of the following inhalational agents can be used for inhalational induction in children? Okay, so the options given are desflurane, isoflurane, halothane and sevoflurane. So this topic again we discussed in detail during our recent INICET Prepathon as well as in our app. So let us just recall some highlights. So I'm using the similar slides that I used in my previous class. So inhalational agents are broadly classified based on their action. So the agents that act with a GABA A receptor predominant activity include ether, chloroform, halothane, enflurane, methoxyflurane. Okay, remember none of these agents are in use now. Okay, so what we use now are isoflurane, sevoflurane, and desflurane. These are the GABA A receptor predominant activity inhalational agents, whereas cyclopropane, which is not in use, nitrous oxide, which we have stopped using or we are starting to stop using, and xenon, which is an ideal inhalational agent. These three are having NMDA receptor predominant activity, and these three are also rarely used now, except for the nitrous oxide in the developed countries, in the underdeveloped countries. So let us see one important feature of each of these agents. So if you can recall, ether was the first ever inhalational anesthetic or the anesthetic agent that was used for successful demonstration of general anesthesia back in 1846 on 16th of October by WTG Morton at the Ether Dome of General Hospital of Massachusetts, and the day is still observed as the World Anesthesia Day, and that is the most important thing to be remembered about ether. So we call it as the Ether Day. This was followed by introduction of chloroform in the year 1847 by James W. Simpson. He was an obstetrician and he recommended use of chloroform for labor analgesia. This was later popularized in 1853 during the delivery of the Queen. Okay, so that is about chloroform. Both these agents were delivered using Schimmelbusch mask. Okay, fine. Coming on to the next agent, that is halothane. Halothane used to be a very popular inhalational agent in most of the developing countries because it had a fruity smell and it was very inexpensive. So it was very popular, and we used to deliver this halothane using Goldman's vaporizer. Remember Goldman's vaporizer, it can come in your exam because it's a historical question and it was never asked before. In this NEET, it can come. Remember Goldman's vaporizer. Okay, fine. Use of halothane was discontinued because of potential risk of arrhythmias and also repeated exposures to halothane, especially to the anesthetist and the people in the hospital OT environment, leading to fulminant hepatitis. Okay, so halothane hepatitis was a risk factor that led to discontinuation of use of halothane in the OT. Remember, enflurane is an agent that can be epileptogenic, and methoxyflurane, even though it was most potent inhalational agent with a MAC value of 0.016, it also was most nephrotoxic. Therefore, the use of methoxyflurane was stopped. Remember, isoflurane can be used as a best inhalational agent, especially for neurosurgery for maintenance of anesthesia. Okay, I'm just telling one important point about each of these agents. Try to remember this because you will not have much time for revision especially since it is less than a month to go for the for the NEET exam. So try to remember these points. Isoflurane, as I said, is an ideal maintenance agent for neurosurgery and most of the long surgical procedures. Sevoflurane, on the other hand, has got a sweet smell, therefore, it is very useful for inhalational induction, especially in pediatric patients. So, if you can see, our question asks which of the following inhalational agents can be used for induction of anesthesia, that is for inhalational and induction in case of children. So, what should be the answer? It should be sevoflurane. Okay, yeah. Remember, desflurane is an agent that produces rapid induction of anesthesia and the recovery is also rapid, but it requires Tech 6 vaporizer. It's a special vaporizer, and also desflurane is quite expensive for use. Therefore, its use is very limited. So, Dr. Vinay says, good evening. Good evening, Dr. Vinay. Dr. Abhirami, good evening. So, that was about the commonly used and the classical inhalational agents. So, coming on to the last three, remember cyclopropane. So, when I say cyclopropane, I remember O and R. So, cyclopropane was stored in orange cylinders. And also, this cyclopropane was highly unstable and it was highly combustible. So, any careless handling of this cylinder could lead to explosion. Okay, that is one of the reasons why the use of cyclopropane was stopped. Okay, yeah. Remember, nitrous oxide, it used to be a very popular agent, a versatile anesthetic gas, but nowadays, because of its side effects or long half-life, they say it takes about 106 years for it to get out of the system completely, we have reduced the use of nitrous oxide, so much so that most of us in our routine clinical practice, we have stopped using nitrous oxide. It is also the least potent and inhalational agent, but very popular because of its second gas carrying property. It also produces mild analgesia and therefore little relaxation for the patient. Xenon, it's an inert gas, as you all know, and it's very expensive. That is the reason why we don't see it being used commonly in our OTs, and it has near ideal features of an ideal inhalational agent. Since it's a ideal gas, ideally we don't use it commonly. So coming back to the question, as we saw, sevoflurane is the induction agent of choice, inhalational induction agent of choice in pediatric patients. Coming on to the second question for the day. A 59-year-old male patient who was given rocuronium during intubation for a major surgery under GA, anesthesiologist fails to intubate. Okay, so it must be a case of difficult intubation. So anesthesiologist has failed to intubate. In that case, he may decide to bring the patient back and he may decide to postpone the case. Okay, so to do that, he has to reverse the patient. So they are asking which of the following agents would be best for reversal in this case. Remember rocuronium, and we discussed this again during our previous INICET prepathon, and there I had put up the slide and told you that there are two classes of reversal agents, mainly anticholinesterase and selective relaxant binding agent, that is sugammadex. So anticholinesterase included neostigmine, pyridostigmine and edrophonium. So here what all options they have given: glycopyrrolate, neostigmine, physostigmine and rocuronium. Sorry, this should have been Sugamadex. Okay. Sorry for that. So, as we studied earlier, the anticholinesterase are neostigmine, pyridostigmine, edrophonium, and neostigmine is often used in combination with glycopyrrolate or atropine for reversal, whereas Sugamadex is a newer agent which selectively binds the muscle relaxant at the neuromuscular junction and displaces it, and thereby it is very useful in producing instant reversal. So this we use commonly for rocuronium. We also use it for vecuronium. Okay, so both rocuronium and vecuronium are readily reversed by Sugamadex, and nowadays we are commonly using this combination in most of the cases, including rapid sequence intubation. So rocuron and Sugamadex is also being preferred for RSI. Okay, this can be asked, remember this point. So the answer here is Sugamadex. Okay, yeah. Moving on to the next question, that is, a young patient given regional block with 0.25% bupivacaine for a minor surgical procedure. So basically this patient has received a block with bupivacaine, and shortly after the injection, patient suddenly became unresponsive, pulse was not recordable, that means he has collapsed or probably he has had cardiorespiratory arrest. So they're asking you which of the following would be the best course of management for this patient. So this looks like a direct repeat from previous INICET. So the ideal response here should be, for a person who is unresponsive and with no pulse, we should ideally be starting CPR. So CPR is there in all the options. Okay, so how do we arrive at the answer here? Okay, what we are going to do is we are going to eliminate the wrong answer. So is there any indication of calcium here? What is the scenario, by the way? So they are saying in the stem, bupivacaine was used for a block. That means they are trying to hint at bupivacaine induced systemic toxicity. So is there any indication for calcium or dobutamine? No, right? Yes. So these two are ruled out. And what is the role of sodium bicarbonate? No role, right? So that is also ruled out. So 20% intralipid, does that ring any bells? Yes. So we read previously, or during last discussion, we had seen that 20% intralipid infusions are treatment of choice for local anesthetic induced systemic toxicity. Okay, since this patient has bupivacaine induced local anesthetic systemic toxicity, we have to give 20% intralipid injection. Before that, to deal with the hemodynamic collapse, we have to start cardiopulmonary resuscitation as per the standard basic life support or advanced cardiac life support algorithm. Okay, yes. So if we can recall, the local anesthetic systemic toxicity can present as CNS toxicity or cardiotoxicity and other manifestations like methemoglobinemia and globinemia and allergy or anaphylaxis. Methemoglobinemia, if you can recall, is common with prilocaine or benzocaine. Okay, so how will the patient present? He can present with mild symptoms like perioral numbness or slurring of speech, which later on progress into CNS symptoms and then become toxic features. CNS symptoms are more common with lignocaine than bupivacaine. So CNS features are more common than CVS features in case of lignocaine, whereas the bupivacaine induced toxicity presents mainly with CVS symptoms. Okay, so the patient can come with circumoral numbness, restlessness, tremors, seizures, coma and arrest. So especially in case of bupivacaine toxicity, we will be seeing CVS toxicity, early features like cardiac excitation leading to tachycardia, hypertension, and arrhythmias, ventricular arrhythmias, leading to on a longer course leading to serious depression characterized by bradycardia, hypotension, and decreased myocardial contractility. Okay, followed by asystole leading to cardiovascular collapse. Okay, remember serious toxicity features are more common with bupivacaine than lignocaine. So how do you manage this? Management is symptomatic and based on the severity of presentation. So first what we are going to do is we are going to identify the toxic features. We are going to stop the surgery right away and secure a definitive airway, especially in case of this scenario, like this patient who was undergoing procedure under regional anesthesia. We are going to stop the procedure. We are going to secure an airway, because patient undergoing procedure under block, usually we do not secure a airway with a tube or LMA. So here what we are going to do is we are going to insert a definitive airway like an endotracheal tube or even an LMA, whichever is available. Then we give 100% oxygen and start bag mask, manual ventilation with bag and mask, and we try to maintain the oxygen saturation and oxygenation and ventilation. If there are seizures, we have to treat it. If there are arrhythmias, we have to treat it symptomatically and as per standard algorithms. And definitive therapy is 20% intralipid infusion therapy. So the loading dose here is 1.5 mg per kg over a minute, followed by up to 2 repeat boluses. And persistent cases, we are giving a continuous infusion of 30 mg per kg per hour, and the patient needs to be shifted to intensive care unit for further management. Okay, so that is the treatment. So coming back to the question, this is a case of bupivacaine toxicity. We have to manage it by intralipid infusion and CPR for hemodynamic collapse. So there was one question on second generation supraglottic airway device. They had given a picture and they had asked you to identify. So the options given here are LMA Fast Track, LMA iGel, LMA ProSeal, and LMA Supreme. So before that, let me again tell you that we discussed this already in the recent INICET recall session, prepathon session. And I had shown you this picture, standard airway set of airway equipments. This particular image was a LMA, second generation LMA, and we also showed you tubes, laryngoscopes, ambu bag, face masks, oral airway, okay, and a stillet and intubating forceps. These things I'm showing again and again because they can come in your exam as well. It's very important. Every year almost one question comes from airway management. So trying to recall the airway devices that we study. Definitive airway devices that are placed below the vocal cords. Examples are endotracheal tubes. Extraglottic devices that are placed above the vocal cords or behind the vocal cords, also called as the retroglottic devices. The examples are combi tube and king laryngeal airway, king laryngeal tube. And the next set of devices is supraglottic airway devices. So this question mainly focuses on supraglottic airway devices which are placed above the level of vocal cords. And we also learnt about the adjuncts and accessories in detail in our previous discussion. So for the images, definitive airway is an endotracheal tube. This is a combi tube with 2 lumens, 1 and 2. Okay, and this is a king laryngeal tube. These two are supraglottic airway devices, or also called the laryngeal mask airway. This is a LMA classic, that is first generation, and this is the second generation device which is asked in this question. Okay, so what are the second generation supraglottic airway devices or LMAs? So there are 4: Fast Track, iGel, Proseal and Supreme we commonly use in the OT on a regular basis. Okay, so what is this? This is LMA Supreme. Remember, these second generation LMAs have two channels. This is a separate channel that provides a path for suctioning. Okay, so they also provide better seal. So they are second generation LMAs. So this is LMA Supreme. It has got a inbuilt bite block like this. Okay, we have the LMA Proseal. This also has a separate gastric outlet channel like this, and it needs a handle for insertion. Just like this, we have the LMA Fast Track, which also needs a handle, and it has got a preformed curvature. It allows insertion of an endotracheal tube through it. So this is used in difficult airways in our OT. This can come in your next exam, that is your NEET exam. Please try to learn or remember these images. Okay, so this is a handy tool for difficult intubation. It's called the LMA Fast Track. This was Proseal. Okay, yeah. So what is the difference? Yes, if you can see, you are able to pass a tube through the Fast Track, whereas Proseal, there's no such facility, but it is flexible because of its wire in its lumen. Okay, so it is little flexible. This also has a dedicated drainage channel, just like this one. See, this tube you're passing here and it's coming out through this, so it's allowing intubation. So this is the tool or the gadget that was asked in your exam. As you can see, the tip here doesn't have a cushion. It is made of gel like material. So this is the gel like cuff. Okay, so this is LMA I gel. It is a very handy tool. Okay, it has got, if you can see, a dedicated port for suction as well. Okay, fine. So the answer for that question was LMA I gel. So coming on to the question from the topic critical care management from BLS. So the question was, effective CPR in adult includes all except. So the options were chest compressions of 100 to 120 per minute. You should allow complete recoil of chest. Compression ventilation ratio in an adult is 30:2, and depth of compression should be 3 to 4 centimeters. So this is again a repeat from previous exams and slightly modified, that's all. Okay, this is as easy as it can get. And remember, you should thoroughly read CPR and Go. You cannot miss this topic. Every class I've told this. So we'll just briefly see what are these chest compressions. They are forceful application of rhythmic forceful application of pressure over lower sternum. It increases blood flow by increasing the intrathoracic pressure and directly compressing the heart. It increases blood flow and oxygen delivery to the heart and the brain. Okay, so it is given at a rate of 100 to 120 per minute, and the depth should be ideally 5 centimeters or 2 inches in case of an adult, and you should allow complete recoil of chest after each compression. So that one slide tells you these three are okay, these two are right and this one is wrong. Okay, yes. And the compression ventilation ratio, that is when do you deliver the rescue breath. Rescue breath should be given after 30 compressions. So you give 2 rescue breaths after every 30 compressions. each breath is delivered over 1 second, and it should you should give such volume that the tidal volume should produce a visible rise of chest. So in case of 2% CPR, if you have intubated the patient, you can give one breath every 6 seconds without attempting to synchronize your breaths between the compressions. So that delivers around 10 to 12 breaths every minute. So remember, the compression ventilation ratio is 30:2 in adults, and the tidal volume should be around 500 to 600 ml. And for children less than 1 year, it is 15:2, and the ideal volume is around 100 to 150 ml. So the answer was, so the option that was wrong was 3 to 4 centimeter of depth. Okay, so that brings us to the end of exclusive anesthesia questions, and now we are trying to discuss one question with slight modification. Okay, so let us try to identify this set of instrument we commonly use in the ICU. So what is this set? Is it central venous cannulation set? Is it cricothyroidotomy set, or ICD set, or tracheostomy set? So basically they had asked pigtail catheter in the exam, but I'm trying to modify this because this can come as a modified question in your NEET. So what is this? This is, let's try to identify this. If you know the answer, you can type in the chat box. Okay, yeah, what is this? Try to identify this. Anyone? Okay, philosophical monk Achu says that it's a central line. Very good attempt, Achu. I'll show you the, okay, this is the central line. Okay, I'll give you the answer. This is the central line. I'll give you the points. Okay, yeah. So no, this is not the pigtail. I have removed pigtail from the question. Okay, this is a modified MCQ which I wanted to discuss with you all because it has lot of image based value, because it can come as a modified repeat. So showing this image, if you can focus here, what is seen on the screen? So you are seeing a syringe, you are seeing a syringe with a needle. Okay, and you are seeing a connector here. Okay, basically a syringe and a small tube like thing. You can still attempt, you can type in the chat box. And we have forceps. Okay, and we have an introducer, we have a scalpel. So what it could be? Yeah, that was percutaneous cricothyroidotomy set. We use this in emergency situation when we cannot intubate or we cannot ventilate. This is definitive airway, emergency definitive airway, or the front of neck axis, what we call. Okay, so similarly we have got this set. What is this? We already saw the cricothyroidotomy set. So any guesses for this? You can comment in the chat box. Okay, so this is similar to the previous set. This is percutaneous tracheostomy set. So here you are seeing the tracheostomy tube. So this is a percutaneous tracheostomy set. Okay, yes. So this is the percutaneous tracheostomy set. So try to identify this. Anyone? So I put 3 images and it was there in the options. What is this? You are seeing a bag here and a drainage tube here and lot of things like the forceps, the blade. Okay, any guesses? Yes, this is the intercostal drainage set, ICD set. Okay, So like philosophical monk said, this set in the question, what we are seeing is central venous cannulation set. Okay. So if you can recall, I told in the previous class, IJV, subclavian vein and femoral vein are commonly used sites for CVC insertion, and IJV usually preserve it for patients who are receiving dialysis. Subclavian vein has got a least chance of infection, and femoral vein, it is the most easiest central line to be passed, especially in case of emergencies or in case of CPR. Okay, fine. So this is a picture showing contents of central venous line set. Okay, let's not go into details. Yes, this is one bonus brownie point, or whatever you can call it, one bonus image for the day. So any guesses for this? You have 1 minute to answer this. Any guesses? Comment in the chat box. What we are seeing here, we are seeing some catheter kind of thing here. Okay, we are seeing some needles. We have some syringe here. So what it could be? Have a wild guess. Okay, so we have two types of sets here, 1 and 2. Okay, so this one is an epidural set. Yeah, good attempt, philosophical monk. This is a epidural set. Okay, we are seeing only one needle here, if you can see, and a well tried, philosophical monk. Okay, and this one is combined spinal epidural kit. Okay, so here we are seeing an epidural needle plus a spinal needle. So in combined spinal epidural, we are going to give epidural plus a spinal. Okay, so we have got both epidural and spinal needles in this set, along with the epidural catheter. And this is the loss of resistance syringe that you're seeing here in blue color. So guys, that brings us to the end of this session. I hope you enjoyed this session, and let me tell you the same thing again. This I had put up in the previous class also. So to succeed in any exam, you need to understand the exam pattern. So what we are having next is NEET, and remember guys, from this session you are having 42 minutes to attempt 40 MCQs. Okay, in this last month, you try to solve MCQs, as many MCQs and grand tests as possible. Okay, and reach that phase, reach that, gain that momentum where it can attempt at least 40 MCQs in 30 to 35 minutes. Remaining 5 minutes you keep for review of each block. Okay, so you'll have 200 questions, and each 40 MCQs you will have one block. Okay, so you have 5 blocks. Each block will disappear after a time frame of 42 seconds. And if you are not quick enough, I'm telling this because plan your exam properly. Recently concluded INICET, some of my students came back and said they could not manage the time well. So this is very important. Time your exam well, plan well, try to solve 40 questions in 30 to 35 minutes. Remaining 5 minutes you keep it for review. Okay, stick to a schedule every day. Have a schedule every day. Plan your day before you sleep or early in the morning when you get up. Stick to it. Keep practicing mock tests. And if you don't know what to read, try to focus on high yield topics. Just do last 5 to 6 year topics. That will fetch you good number of marks. And try to stay as healthy as possible. So the trick to succeed in this exam is eating healthy stuff and managing your time and stress in a smart way. Work smart and work hard as well. Okay. So thank you for watching this session. As I said, all these questions are already discussed in our app. So try to download our app from Google Play and or from the App Store. If you're not subscribed to MedAce channel, subscribe by pressing the bell button now only. You can also follow us on all the social media accounts, and do find the link in chat box for my previous session, that is this one, INICET Prepathon. Okay, this session is a almost three and a half hour session. There I have discussed all the important topics that will come in your NEET as well. So thank you guys. Have a good evening. Good night.